Hi, everyone. Welcome to another Shop Talk. My name is Chad Cook, and we're very lucky today. We get to have a Shop Talk with Dr. Paul Mintken. And we're going to be talking about one of his classic papers from 2016 that was published in JOSPT. Paper's title is Cervical Thoracic Manual Therapy plus Exercise versus Exercise Therapy Alone in the Management of Individuals with Shoulder Pain, a multi-center randomized controlled trial. So Paul, welcome. I know everyone probably knows you already, but do you mind just giving a brief introduction of what you're doing now and your research background and just anything you want to talk about?
Yeah, well, first off, thanks for having me on, Chad. What comes around goes around, huh? You came on our podcast, but so currently I am a professor in the new hybrid DPT program at Hawaii Pacific University after retiring with a pension from the University of Colorado after 28 years. So that's a nice added benefit. I have 3 kids just entering college, so I'm going to need as much money as I can get. So I started out as a full-time clinician and worked for 10 years back in the 1990s when things were really busy and it wasn't unusual to see 25 patients a day. And after that 10 years, I was really burned out and was ready to leave the profession when 3 kind of fortuitous things happened. Number one, I decided to pursue my OCS to kind of advance my knowledge because I knew I was not evidence-based at that time. I stumbled into an academic position at the University of Colorado teaching the musculoskeletal content, which was kind of new and exciting to me. But I also met Tim Flynn and Julie Whitman, who kind of became my mentors and inspired me to do the fellowship. They were at Regis at the time in manual therapy, and that really ignited a fire in my belly to kind of up my game, increase my toolbox, and get involved with clinical research. So Julie at that time had her clinical prediction rule on manipulation for patients with ankle sprains. And Josh Cleland was also in the fellowship with me at that time. So we kind of became fast friends, and he kind of took me under his wing on his meteoric rise back in the 2000s. And so I kind of became a data collection machine for Julie and Josh. And as you know, we get these people come up to us at conference and say, how do I get involved in clinical research? Well, that's what I did. I said, I've got patients and I can collect data for you. And so I just collected a lot of data, kind of proved my worth to them. And they started throwing me some bones and helping me to come up with my own clinical research ideas, which led to my interest in thoracic manipulation for patients with shoulder pain. So, and I also have to give a shout out to Dr. Jennifer Stevens-Lapsley at the University of Colorado, who helped me get my first publication, which was a case report based on her research using electrical stimulation in patients with total knee arthroplasty. So I really had some great mentors to kind of guide me in the process, and I've utilized that team all along, and have realized it's a team effort. So it's all about who you get together, and you can really do some great things. So that's kind of my background there.
Yeah, that said, you had some stars on this paper. I mean, you had Josh and but you also had Laurie Mishner, who she was not at USC at the time, though. She was in Virginia, right?
Yeah, I think she was in transition at the time. So yeah, but she's very busy and just what a smart lady she is. Holy smokes. So
Yeah, she is. You had Scott Burns, Amy McDevitt, I mean, and Rob Boyles. He had it was like a talent pool there. That was tell us what it was like when you were kicking around this idea, because what we like to do at Shop Talk is we like to just get the backstory on why did you decide to tackle this as a relatively big project, an RCT. Why did you decide to tackle it?
yeah, well, the first idea that Julie and Josh kind of let me run with was coming up with a clinical prediction rule. You remember the day when those were the flavor of the month or whatever. So we wanted to try and determine which patients with shoulder pain would benefit from thoracic manipulation, which was based on this huge body of research that supported this kind of regional interdependence approach with the thoracic spine and the shoulder. Coming not only from the posture and the biomechanics standpoint, you have to have a certain amount of thoracic mobility for your shoulder to function normally, whether you have pain or not. But they've also, found significant improvements in individuals that have some impairments there, and you treat those, and then you can make within session changes in painful arc and impingement signs like the near sign and Hawkins sign and that type of thing. So that was the first step. We published that clinical prediction rule in PTJ in 2010. And so that kind of led us to think, okay, this is a single arm trial, low level of evidence, that type of thing. So we wanted to kind of do a randomized controlled trial, number one, to determine if the clinical prediction rule was valid, but number two, to determine if adding thoracic manual therapy to a good evidence-based exercise program, which we know the value of, would add any benefit overall. And I have to give a shout out to the editors of JOSPT at the time, because we were just going to do all this in one paper. But Guy Simoneau and others suggested that this should really be two papers. One, looking at the validity of the clinical prediction rule, which it wasn't valid overall. But number two, really doing a randomized controlled trial to determine, the added value of thoracic manipulation for patients with shoulder pain.
Again, you had a really well-designed exercise program. Both groups got that, but one of the groups received manual therapy, some cervical work, mostly thoracic work is what it looks like from the pictures. Why don't you tell, or just remind our folks what your outcomes were?
Yeah, so the outcomes overall, well, we had 2 sessions of manual therapy, and while the individuals that were getting manual therapy for those first 2 sessions, the group that was randomized to exercise also got cervicothoracic mobility exercises. So they were mobilizing their own thoracic spine and cervical spine at the same time, which is kind of a confounder overall. But we did not find in the legacy outcome measures, which were the SPADI and the quick dash and the NPRS, that there was a significant difference between the groups at 1 week, 4 weeks, and 6 months. So,
were you surprised by that finding, Paul?
Well, my bias as a manual therapist is that, these techniques have some value. And I think the good news is most patients improved. The average change in the SPADI exceeded the MCID at 4 weeks and 6 months in all the individuals, but obviously we were hoping for a different outcome, which reveals my bias, which is a whole separate discussion. But the data is what it is. We could have tried to manipulate the data, but based on our primary outcome, which was the SPADI, the results were not significant. So I love that Mark Twain quote where he wrote, there's 3 kinds of lies, damn lies, and then statistics. And really with a data set as large as ours, you can find ways to support your bias if you massage the data here and there and that type of thing. But, when it came down to it, based on the outcome measures we chose, it was not significant overall. So.
No, I appreciate that. And I appreciate, especially when individuals have a particular area they're interested in and they don't find a difference, it makes me believe those individuals even more. But your group had the foresight to also capture the GROC and the PASS. And can you talk about your findings, between group findings with those?
Yeah, so we did find a greater percentage of the individuals in the manual therapy plus exercise group had a successful outcome on their acceptability of symptoms, which was measured with the global rating of change and the patient acceptable symptom state. And so these are single questions that allow the patient to take in, all that they have going on with their lives and rate the impact of their condition on this. So the question in the global rating of change is, please rate the overall condition of your shoulder from the time that you began treatment until now, from a -7, which is a very great deal worse, to a +7, which is a very great deal better. And they just say, where are they at that stage? The PASS, I really like that one. The question is, taking into account all the activities you have during your daily life, your level of pain, and also your functional impairment, do you consider that your current state is satisfactory? And the answers are yes or no. So I really like the binary fashion there. The legacy outcome measures that we use, like the SPADI and the quick dash, we're looking for the MCID, which may or may not be meaningful to the patient. So I do really like the the grok and the pass.
Yeah, I think it's interesting. Your paper and then a paper by Sean Riley and then a paper by Megan Donaldson all found where none of the legacy measures didn't find a difference between two groups, but there were differences with the grok or the pass. And so it's 3 papers now that have found this, which I find to be interesting. My feeling is, and I'd love to get your thoughts, I think they measure 2 different things. The legacy measures are health status measures, whereas the grok and the pass are really perception measures by the patient, which may be why we're seeing that in the studies that have looked at it. But what are your thoughts?
Yeah, those legacy measures, number one, a lot of them were created a long time ago with questions that in today's society may become less and less valid overall, but I don't think they really capture what's important to individual patients. They're great for large groups and things like that, but when you talk about the patient sitting in front of you, so many times patients will tell me that the outcome measure doesn't ask them about specific activities they are having difficulty with. So there may even be questions on there that they're like, I don't do that, so I have to hypothesize, how it would be if I tried to do that. So, those legacy outcome measures are certainly limited overall. So clinically, I really like the grok and the pass. I really love the patient-specific functional state where they get to create the outcome measure. Basically, they come up with 3 activities that they're having trouble with, and they rate it on a 0 to 10 scale, and then you can reassess that as treatment goes along. So
yeah, I agree with you. That's really nice. So it was a big study. You had 6 sites that you held enrollment. Tell us, and most people will go their whole life never running a randomized control trial. So give us a perspective of what the effort was like to coordinate 6 sites and all the enrollment and just making sure the communication and everybody's doing things the right way. Yeah, just give us some perspective on that.
yeah. A monumental task is what I'd say. It was challenging in the beginning, and we were talking before we started here about the IRBs. IRBs are becoming so entitled, I guess is the word, where they want to comment on, they want to change the study here. So you got 6 IRBs looking at this study, and they all want to make little changes to it. So you end up with different studies at different sites and that type of thing, and it's really challenging overall. So that was the first hurdle to get over. But then we had to train all the data collectors, try to standardize everything we were doing from the examination to the treatment. This meant a lot of travel and Zoom calls. And then we tested all the participating clinicians to try and develop a certain level of competence to make sure we're all delivering similar care. And as you know, enrollment can be challenging. We had a few sites where access to care was really challenging. We had one on a reservation in Northern Navajo Medical Center where Joe Struntz and Steve Spoonmore were. They had a 64% dropout rate at 4 weeks. And this was due to the patients didn't have a car. They lived an hour away and they didn't have a ride and things like that. So we had to enroll 140 subjects, 8 sessions each. So coordinating this was a nightmare. And I have to give a shout out to Amy McDevitt. She was just coming up as a researcher at that time, and she took charge of a lot of this and really handling that minutia, which is not one of my strengths. So to me, it's really important to have a really diverse team overall. As I mentioned before, I don't have a PhD, so my knowledge of study design and statistical analysis is not great overall. So I really see my role as kind of a clinical expert to come up with the ideas and then use these other people like Lori Michener and Josh Cleland to help figure out how to make it happen and analyze the data and tell me what it means, basically. So,
yeah, you built. I mean, I got a chance to read it again this morning just before we talked, and it's very comprehensive. I mean, the intervention is well detailed. Even the home program is really nicely done. Is there anything you would do now, knowing what you know? I mean, this is 2016, right? Is when you published it. What would you do differently about this, just knowing what you know right now?
Yeah, hindsight's always 2020, right? But first off, what I alluded to earlier, when the individuals randomized to manual therapy got manipulation, the exercise group was mobilizing their thoracic spine and their cervical spine. So that's confounding right there. They're targeting the same type of intervention, just a different approach to it. So I probably would have started the exercise group just right off on the exercise and not had them treating their own thoracic impairments and things like that. Second, I probably would have tightened the inclusion criteria to limit the pain to the shoulder. We kind of used Bergman's definition, which was from the neck down to the elbow. So a pretty big area overall. I also probably would have limited chronicity because we had the average duration of symptoms in the study was 2 years or more in both groups. So we had a lot of subjects that had had symptoms for a long time and had tried, pretty much everything else conservatively. So, and then the final thing is, we've talked about prescriptive versus pragmatic and that kind of thing. This was a very prescriptive study. And it would have been interesting to see if we would have allowed the clinicians to treat the patients more pragmatically and not limited it to, after 2 sessions, you can't touch them anymore, that kind of thing. That's not how we practice clinically. So I really wish I would have had a pragmatic component to it. So,
we had a similar study where we just used cervical mobilizations and manual therapy for patients with shoulder impingement. And we found similar results to you that didn't see a difference between the two groups. And we also had really severe shoulder problems that on average, I think were close to 2 years that they had their symptoms. And I was reading in your introduction, I was a little surprised at how low the recovery rates are for shoulder injuries and how high the recurrence is. And when you did the write-up for the introduction, I mean, were you aware that the conservative outcomes for shoulders were that bad?
Yeah, I'd done that literature review. I'd been working on this topic for 7 or 8 years at that time, probably closer to 10 years, I would say. And I knew the outcomes were not great. And, clinically, we do see that, patients, once they develop shoulder pain, especially if it's more of a mechanical kind of thing, it tends to linger, kind of like low back pain. So, the lifetime prevalence is up to 67%, and the 18-month recovery rate is anywhere from 50 to 60%. So that means 40 to 50% of patients still have shoulder pain a year and a half out. And those patients that do recover, 1 in 4 will have a recurrence in the first year. So, I think the biggest contributor to recurrence, in my opinion, is that patients don't know what's going on, number one, and they don't know what they should do about it. So I think getting the right message at the right time can make all the difference. We use our arms a lot, and upper extremity function is so multifactorial that I think patients just don't know what's okay to do and what's not okay to do. So they keep kind of using it and irritating it. And once it gets to the stage where the tissue should have healed in the allotted time frame, it really takes a skilled clinician to identify all the variables, both physical and psychological, that may be contributing to the patient's condition. And I just don't think that's done. And most patients go see their primary care doc and they're like, come back and see me in 6 weeks if it's not better. Well, at 6 weeks, they're like, well, I'm not going back to that guy. He didn't do anything for me, or that gal, So I think getting in to see a physical therapist is really paramount in shoulder pain.
No, that's a really good point. So, Paul, I know you practiced in the clinic when you were in Colorado, and I think I emailed you the other day, and you had times that you were still in the clinic. You're still in the clinic now, right?
Yep, 1 day a week, still doing that. All through my academic career, I've been in clinic anywhere from 20 to 50%. Yeah.
Yeah, I mean, you're kind of recognized as a master clinician, and I'm just going to ask you clinically, knowing what you know with this study and some of the other work you've done with the shoulder, do you still use manual therapy at the neck and the thoracic spine when you deal with patients with shoulder problems?
Yeah, absolutely. I don't think this study proves that manual therapy is not useful for these individuals. And you've seen it and I've seen it. And I really have to give a shout out to the Maitland kind of approach. I took all the courses through OZPT back in the 1990s with Bob Sprague when he was still around, and with Roland Lucas and that type of thing. And they really drilled into me this value of the test retest kind of an approach. And if I can see an immediate change, number one, patient has shoulder pain, they've got a painful arc. Okay, let's change your posture. Let's recheck that. Wow, that's better. That's moving better. Well, you're a little stiff back here. Let's treat that a little bit and see if that improves your symptoms. So you go in and manipulate the thoracic spine, and all of a sudden, wow, they've got full pain-free range, when before they came in, they couldn't get to 70 degrees without pain. So, RCTs are nice, but they can't tell us if an intervention is going to help the patient that's sitting right in front of us. And I really rely on kind of that test retest approach to determine, is this a valuable intervention or not? Some patients it does nothing, but some patients it's dramatic. So
well said. And I mean, RCTs are great for identifying snake oil. They're not good for identifying who's likely to be a responder from an intervention. And I think many people misconstrue that when they look at an RCT. So, and I love hearing you talk about Bob Sprague. Bob was a mentor of mine too. I took all the OZPT courses as well. I have a Maitland background. I think you and I have very similar years of experience and years of academic experience. I was also in the clinic for 9 years before I got into academia. You're above me. I think you're longer than me. So I've got a couple more questions for you, if you don't mind. The first one is that let's say you're at AOMPT and there's a whole slew of students are in the elevator with you. They hadn't read your paper yet. And you had a minute to tell them, just a quick results, but really more the takeaway from this. What would you say?
Yeah, I would say that there's a body of evidence that supports that treating the thoracic spine can result in some pretty immediate changes in both pain and range of motion and function in patients with shoulder pain. But when you compare it to doing, probably the most powerful tool we have in our toolbox, which is exercise, manual therapy may have limited value at a long-term outcome like 6 months and that type of thing. But I really view manual therapy as creating a therapeutic window which allows patients to move with less pain and fear and ultimately get to doing what the research says is the most powerful intervention, which is probably exercise. So we can induce some short-term improvements in pain and function that allows patients to start moving earlier with less pain and fear and anxiety and that type of thing.
Yeah, really nicely said. We've got a paper that's been languishing in review forever. Shoulder impingement, 2 groups, both received really high quality exercise. And one of the groups received a health coaching and a lot of pain science and a number of other things, no effect whatsoever. But what we found is the exercise is so powerful that it really probably swamped all of the change in the patient. So exercise is definitely, I think it's the go-to for the shoulder for sure. So Paul, I love the fact that you have retired from mainstream academia, but you have your new position, and it sounds like you're loving it. What else do you have brewing? You made the guitars in your background. That's pretty amazing. But what else do you have brewing that you can tell that you've got going on right now that you can share?
Well, I'm part of the team that's updating the clinical practice guideline for neck pain, which is going to involve some systematic reviews and that kind of thing. And my group is specifically focusing on the manual therapy for neck pain and that type of thing. So that's a large project that we have going on. And, I've been trying to get back into presenting since COVID. I kind of took a break during COVID and didn't present at a lot of conferences. So in the next 8 weeks, I have 5 or 6 conferences, including an international one that kind of jumping back into the fray there. So, I really view my role at this point is to kind of synthesize, what the knowledge that's available and try and distill it down to people. I'm not very good at granular kind of things, but I can take a step back. I love Julie Fritz. She likes to take that 20,000 foot view of physical therapy as a profession. And it's not this manual therapy technique or this manual therapy technique. It's a package of what we do as a profession. So.
Yeah, I agree. We kind of went technique versus technique crazy for a while. And yeah, I think it's more comprehensive than that when you're dealing with a patient.
Yeah.
Let me ask, if somebody wanted to contact you or follow you on social media, do you have, I know you're on Twitter. What's the best way to get a hold of you or to follow your work?
Yeah, the best way is probably Twitter is where I try to post any new studies that come out. So it's at Mintken DPT is my handle there, but certainly people can reach out and email me. You can just type my name in Hawaii Pacific and my email will come up and you can shoot me an email. I love getting emails from people that ask about my studies and that type of thing. So I'm also on Facebook, but really, I've been reading a lot of books about social media and the foundations of Google and how they really try to suck people in and addict them to scrolling and things like that. And I'm and you've experienced it on Twitter, the negativity and that type of thing that, I have to balance how useful is it as a tool versus, potentially harmful overall, risk versus harm, just as what we do as researchers and that kind of thing. And I'm really coming away that, social media is not a place I like to hang out much. So,
Not healthy.
yeah.
Yeah, I'm with you there. I have cut down my interaction on social media dramatically, and because I've also muted a lot of negativity where you can go in and mute so you don't have to see anybody's posts, and it's certainly made life a lot more positive. That's for sure.
Yeah.
Paul, thank you so much for being on. Really appreciate all the work that you've done. You're a person I wanted to get on Shop Talk, so I'm so glad you agreed.
Well, thanks, Chad, for having me on. And, you've been a role model for me throughout the years as well. And so when I have difficult questions, I love reaching out to you and asking. So thanks for all you do for the profession as well.
Appreciate it, Paul.